Our sexual rejuvenation programs use advances in the field of regenerative medicine to help you heal. Regenerative medicine is a modern field that aims to regenerate damaged tissues in the body. In other words, to heal. It may be defined as the process of replacing or regenerating human cells, tissues, or organs to restore or establish normal function. This list comes directly from the American Urological Association's Guidelines on ED, published in 2018. This is what their expert panel has concluded should be offered by urologists based on published peer-reviewed scientific articles. The first thing they mention is mental health support. They also recommend lifestyle changes because ED is associated with risk of heart disease and has been shown to improve with measures such as exercise. Pharmaceuticals come next in their list, and this includes oral medications such as Viagra and Cialis, suppositories that are inserted into the urethra through the opening at the tip of the penis, and injections into the penis like Trimix or Caverject. Testosterone therapy is also noted to improve erectile function. Penis pumps are recommended, as are penile prosthesis implantations. They do address two regenerative therapies, low-intensity extracorporeal shockwave therapy and platelet-rich plasma therapy, which is the P-shot. Because of their interpretation of the published evidence on each of these, they conclude the former should be considered investigational and the latter experimental. Let's talk more about that evidence. The American Urological Association review panel concluded that low-intensity shockwave therapy should only be offered as an investigation because randomized trials do not clearly indicate that the benefits reliably outweigh the risks/burdens. But later in the guideline, they specifically state that there are no risks. And I quote, "There were essentially no adverse events reported in the group of studies reviewed." As for efficacy and burdens, they state, in particular, the treatment's ability to restore normal erectile function remains in question. The duration of treatment effects beyond possible short-term efficacy is not well established, and the burdens associated with obtaining the treatment, i.e. time and cost, are substantial. Given the availability of other treatments that are less burdensome and known to be effective, and the fact that extracorporeal shockwave therapy is not FDA approved, the panel concludes that this should only be used in investigational settings in the context of an institutional review board IRB approved clinical trial. Now, as far as conducting an IRB approved clinical trial, that is an involved process that is typically mainly available in large medical centers and hospitals with outside funding. But we are looking into it, and if it is an option for us, we will conduct trials. As to the other concern, I'll review the burdens and risks of this and the other standard treatments the AUA recommends, so you can be the judge of the amount of burden and risk you find acceptable for yourself. I will address the FDA approval question, and I will show you why my assessment respectfully differs from the panel's. This and the next slide show the AUA summary of the evidence on low-intensity shockwave therapy for ED. The AUA's panel found 7 randomized controlled trials in which men did not know whether they received real extracorporeal shockwave therapy or a fake treatment. 4 of the trials were on men who had some response to PDE5 inhibitors. That's the group of medications that includes Cialis and Viagra, but they weren't allowed to use the medications during the treatment protocol. The AUA guideline states all 4 trials showed statistically significant improvements in erectile function without PDE5 inhibitors in response to shockwave therapy, but not the sham treatment. That sounds like pretty great evidence to me. They then state that no man returned to completely normal erectile function, suggesting the need for adjunctive ED therapy. In the next slide, we'll look at how much these men did improve, which was actually quite significant. Finally, as to risks/burdens, they state, there were essentially no adverse events reported in this group of studies. The most frequently reported reason for participant dropout was the inconvenience and/or cost of obtaining the treatment. Let's pause for just a moment to look at how erectile function is measured. This is a copy of the SHIM score, which stands for Sexual Health Inventory for Men. This is an abridged and slightly modified 5-question version of the 15-question International Index of Erectile Function, and it's been designed for easier use. The SHIM includes the most relevant practical questions, and so we use this to track improvement in our patients over time. This and the similar International Index of Erectile Function EF score, which is an excerpt of 6 questions from the larger 15-question score, versus our SHIM score, which is 5 questions, are used in many of the studies I am about to show you. So back to the AUA guidelines research. The AUA reports that 2 of the 4 randomized controlled studies looking at Gainswave without PDE5 inhibitors showed significant improvement included long-term follow-up of a year. In these studies, erectile function was measured using the 6-question IIEF-EF. That's the erectile dysfunction severity score, and it asks 6 questions about erectile strength, orgasm, desire, satisfaction with intercourse, and overall satisfaction. A completely normal score is 26 to 30. As an aside, the slightly modified 5-question version of this score that we use, the SHIM, has 5 questions rather than 6, so optimal on our test is 22 to 25, with 25 being the highest possible score. So the first of these 2 studies showed that at baseline, before anything was done, the groups were well matched. Those who got real treatment and the group who got fake treatment had similar scores, around 9, which is a low score indicating significant ED. 1 month after treatment, the score had improved to 22 in the treatment group, which is almost perfect. These men went from severe ED to very mild ED. I'd say most men would consider that a success. At 1 year, the improvement declined slightly so that most men had mild to moderate ED. Again, although there was a decline, these men still had a score of 18.2 instead of 9. That is still a dramatic result. The AUA states they are concerned with this decay because it suggests many men will require another ED therapy. This critique centers around the goal being a return to 100% normal erectile function, but that is not a standard that any conventional therapies meet. Shockwave therapy clearly improved erectile function in a meaningful way, and even with the slight decline over a year, with no further treatments, these men were still much better off than before. In contrast, all conventional therapies, other than the insertion of a penile implant, require ongoing use for any results. In another study the AUA reviewed, they reported that at 1 year the results weren't great. However, they also note that 75% of the men who were treated reported a minimal clinically important difference compared to only 25% of those who got sham treatment. In this study, they also used actual ultrasound to evaluate penile blood flow and found a dramatic improvement from 0.6 centimeters per second to 4.5 centimeters per second 3 months after treatment. It's important to clarify what a minimally clinical important difference is. Basically, the authors of this study required a much greater improvement for men with severe ED than for those with mild ED to even count their results as positive. Minimally clinical important difference is a better research assessment than statistical significance because it looks only at differences that actually have a meaningful effect on a patient's life. In other words, all of those 75% of men who noted improvement at 12 months had a meaningful improvement. So here we have a significant degree of improvement in 3/4 of men at 1 year after treatment, and we have ultrasound findings at 3 months after treatment proving the physical effects. This is a gold standard randomized controlled trial with a blinded placebo group. This same author has also done a study, which was not included in the AUA guidelines review, looking at 6 versus 12 treatment over 6 weeks, either once a week or twice a week. Men were randomly assigned to have 6 weeks of treatments. Group A got 1 treatment a week, and Group B got 2 treatments a week. 6 months later, the groups were switched, and each got another 6 weeks of treatment, this time twice a week in Group A and once a week in Group B, bringing each group up to a total of 18 treatments. None of the men were allowed to use PDE5 inhibitors like Viagra for 4 weeks before the treatment or at any time during the study. They found that after 6 treatments, 47% of the men could maintain an erection throughout a sexual encounter, and 65% of those who got 12 treatments could. The majority of the men, 62% of those who had 6 treatments, and 71% of those who had 12 treatments reported clinically meaningful responses. After the 6-month repeat treatment, Group A, who had had 6 treatments and now got another 12, improved from 47% being able to maintain an erection throughout sex to 61.9% being able to do so. Group B saw a smaller improvement. Overall, after 6 sessions, 62% of men had a meaningful response. After 12, this was 75%. And after 18, this was 83%. The authors concluded that repeating the treatment is safe, doing 12 treatments in the first 6 weeks is safe, and that additional treatments provide additive effects. Again, this is excellent evidence that this treatment works. The author whose studies we've just reviewed has done excellent studies on shockwave therapy for ED, and he makes the following conclusions. Shockwave therapy should not be considered experimental, as there is excellent evidence supporting it, of which you have just seen many examples. The treatment protocol has also been demonstrated to be safe with no major side effects other than occasional tenderness or numbness in certain parts of the penis that go away in a couple of days. There is even evidence showing that shockwave therapy is safe for patients on anticoagulants. And finally, shockwave therapy is the only therapy that reverses the pathology that caused the ED. He cites evidence that at least half of patients continue to have benefit up to 2 years after treatment. He concludes this is the most appropriate therapy for ED and calls for shockwave therapy to be the mainstay of a new paradigm in the treatment of erectile dysfunction. And before we move on to what to expect during treatments, I do want to share the evidence on shockwave therapy for Peyronie's disease. The American Urological Association's guidelines were most recently updated in 2015. Peyronie's disease is a condition in which thick scar tissue forms on the penis that causes curved and sometimes painful erections. The AUA recommends anti-inflammatory medications for pain. They recommend several types of penile injection therapy directly into the area of the plaque. With these, modeling of the penis may be done, which is basically stretching and pulling the penis into a straight position while healing occurs. For each of these injections, the AUA states that the risk should be carefully disclosed. The first injection recommended is a collagenase injection called Xiaflex. Collagenase is an enzyme that breaks down tissues. The risks of this include bruising, swelling, pain, and corporal rupture. Corporal rupture is a condition in which the sheaths that surround the parts of the penis that hold blood during an erection actually rupture or tear, leaking the blood out and causing issues with erections. This tends to happen in the first month after the injection. And when I trained on this technique at a urology conference in 2019, the physicians who trained recommended that patients avoid intercourse for 1 month after the injection is performed. 2 other injections are also recommended. One is interferon alpha 2B, which includes risks of sinusitis, flu-like symptoms, and minor penile swelling. And the other is verapamil, which includes risks of bruising, dizziness, nausea, and pain. Shockwave therapy has also been used for Peyronie's disease. The panel concluded that it clearly reduced pain from Peyronie's disease, but did not reliably improve plaque size or curvature, and thus should not be recommended for these reasons. It is worth noting that it did improve these in some studies, but not the majority, and it did not make them any worse in any reports. We'll take a closer look at that data. Finally, surgical options are recommended. Men without ED can undergo surgery to either lengthen the side of the penis with the plaque by cutting into the plaque, removing it, or putting a graft, such as with cheek tissue, into the penis. An alternative is to plicate the other side of the penis, which means putting sutures into that side to shorten it so that it matches the length of the side with the plaque and the penis doesn't curve as much. Men with ED are advised to have an inflatable penile prosthesis implant instead, as this allows for straightening of the penis, and when inflated, the penis will be hard enough for penetration. These guidelines do not address the use of platelet-rich plasma, the P-shot, for Peyronie's disease. This is reviewed in much more detail in my other presentation. This is what the AUA guidelines report on the use of shockwave therapy for Peyronie's disease in terms of its effects on curvature and plaque size. They reviewed a total of 19 studies, 3 of which were randomized controlled trials, and another of which was randomized but did not include a sham group, and the remainder of which were observational studies. Men had 4 to 6 weeks of treatment at 1 treatment per week and were followed for 1 to 6 months. None of the studies demonstrated benefit of shockwave therapy for curvature or plaque. 1 study reported no change in the treatment or sham groups. Another reported small changes in both groups, and a third reported small improvements in the treatment group, but they weren't statistically significant. The observational studies reported conflicting findings, ranging from no improvements to large curvature decreases, and from 0 patients experiencing benefits to 75% of patients experiencing benefit. Overall, 5 of these 15 studies showed no benefit, while the remainder did. To me, this evidence suggests that the jury is still out on using shockwave therapy for curvature and plaque size, that it's not harmful, and that it probably should not be used alone for the treatment of curvature or plaque unless we get new evidence. For the use of shockwave therapy for pain due to Peyronie's, the AUA panel summarized research as follows. There were 3 randomized controlled trials and 1 randomized with no control or sham group. In the first, 85% of men reported decrease of pain from 4 to 1.5 on a scale from 1 to 10. In the control group, pain scores improved in 48%, but only from 4 to 3. In another study, pain improved from 5.5 to 0.46 at 24 weeks, and in the placebo group from 5.2 to 2.7. This is likely accounted for because Peyronie's naturally improves over time, but you can see the improvement was greater in the treatment group. In the third study, shockwave therapy alone versus shockwave therapy with the use of Cialis was considered. Pain scores improved in both groups, from around 5 to less than 1 at 24 weeks. The final study did not show much improvement, but it started with men whose pain scores were only 1 to 2 on average, which is very low on a scale of 1 to 10. This would make it very hard to see any improvement in pain when pain in this group was already so minimal. The panel interpreted these data to mean that shockwave therapy may reduce pain from Peyronie's disease, and I agree, the evidence is compelling. My conclusion is that shockwave therapy has never been reported to worsen Peyronie's disease and could help with curvature and plaque size, though the data suggests this may not be true. It is clearly effective for pain, and it is certainly reasonable to use in conjunction with the P shot to improve blood flow or in men who have both ED and Peyronie's disease. Again, please see my other talk for more information about the P shot. Now, there are a few precautions to take for those who have medical issues. Non-steroidal anti-inflammatory drugs should be stopped at least 2 days before the procedure and ideally held as long as possible afterwards, up to 6 weeks. Blood disorders such as clotting issues put you at a higher risk of complications from any procedure, as does immunocompromise. The procedure cannot be done if you have an active infection or active tumors or cancer at the site of treatment. Finally, penile sexual rejuvenation therapies are not appropriate for men with penile prostheses implants. Our protocols for erectile dysfunction include 6 or 12 treatments, either administered weekly or twice a week. We use settings based on research and deliver the treatments into several regions of the genitals where we want to enhance blood flow. For Peyronie's disease, we typically recommend 6 treatments or more depending on the degree of ED, with 2 P shots separated by 2 to 3 months. Shockwave therapy is also used for musculoskeletal conditions such as plantar fasciitis, and the treatment dose for those conditions is much lower than that needed for ED. We recommend several additional therapies to support healing and offer these in packages or on their own. For nitric oxide support, we generally recommend a form of L-arginine, which is what nitric oxide is made from. We have this available in pill or powder form. We also usually recommend daily low-dose Cialis, which blocks nitric oxide breakdown to support and maintain good blood flow during the healing phase. We cannot include this as part of our package, but a local pharmacy offers great prices on a 90-day supply. We also recommend Arterisol, which is a seaweed extract supplement known to support healing of the blood vessel lining. A penis pump is used daily to draw blood into the penis, which is how healing immune cells are able to get to work. The penis pump also may help with remodeling for those with Peyronie's disease. And finally, many men benefit from bioidentical hormone replacement therapy to boost their testosterone levels during the healing phase. Testosterone is a strong promoter of healing and growth. At your first treatment, we apply a topical anesthetic cream. For later treatments, you may choose whether you want to use the cream or not. About half of our patients choose to continue to do so, and about half do not feel it is necessary. On occasion, during the treatment, some men do get erections. If that happens, we just pause the treatment, step out of the room, wait a few minutes, and come back when you're ready to resume. The total time in the office should be under 30 minutes, unless you opt to include hyperbaric oxygen therapy, which will require you to be in the office for another 45 minutes to an hour. Once the treatment is complete, you're free to go. You can return home or go back to work. Afterwards, you may take a light shower or bath the next day. We recommend you be gentle with the area for at least a week. Bruising and some small areas of numbness may occur and last for a couple of days, though most do not experience this. Continue to avoid NSAIDs such as ibuprofen and Aleve for 2 to 6 weeks, as these interfere with the healing inflammatory response. Don't use ice in this area for at least 2 weeks. Continue using recommended medications and supplements. Use the penis pump at least once a day for 5 minutes. And if you opted for a package that includes bioidentical hormone replacement, follow up for that portion of your care as directed during your visit. We love to follow up in 2 months to see how you've done. This can be done over the phone or Zoom if you're not coming into the office for another reason. In summary, low-dose shockwave therapy is an excellent option for sexual health. Multiple studies have shown efficacy with no side effects other than occasional mild bruising or tenderness that may last a few days. Shockwave therapy has been proven to improve blood flow and support healing. We use an FDA-approved device off-label for your treatments, and we feel shockwave therapy is a safe and effective option for many conditions, including male sexual health. Combining this treatment with other therapies truly has the potential to help you reach your sexual goals. We are thrilled to be able to offer this therapy at Integrative Health Matters. To me, as a urologist, it allows me to offer so much more to my patients. We at IHM look forward to hearing from you.